Namaste and greetings. I am Mansi Verma, researcher at IMPRI Impact and Policy Research Institute, Prabhav और नीति अनुसंधान संस्थान नई दिल्ली. Extend my warmest welcome to you all to IMPRI Web Policy Talk. Today we gather for a panel discussion focused on medical life support, withdrawal and assisted deaths, social, ethical and legal issues, a critical discussion on medical life support withdrawal and assisted deaths in India, examining the social realities, ethical dilemmas, and evolving legal framework shaping end of life decision making, organized by the IMPRI Center for Human Dignity and Development. This panel discussion examines the complex clinical, legal, ethical, and social cultural dimensions of end of life decision making in India, particularly in relation to the withdrawal of medical life support and assisted deaths. From the physician's perspective, end of life care involves difficult judgments around prognosis, medical futility, patient autonomy, and professional responsibility, especially in a healthcare system where palliative care remains unevenly integrated. The discussion also engages with India's evolving legal framework, including Supreme Court rulings on passive euthanasia, living wills, and informed consent, while highlighting persistent gaps in awareness and implementation, bringing together legal and ethical perspectives. The session explores how issues of autonomy, vulnerability, socio-economic inequality, cultural attitudes towards death, and family expectations intersect with medical practice and policy, and what this means for advancing compassionate rights based and ethically sound of life care in India. The chair and moderator is Dr. Amar Jesani ji, independent researcher and teacher, bioethics and public health, editor, Indian Journal of Medical Ethics, visiting senior fellow IMPRI. Today's expert panelists include Dr. Dhvani Mehta ji, co-founder and lead Health Vidhi Center for Legal Policy, Dr. Kaustubh Joag ji, consultant psychiatrist and senior research fellow, Center for Mental Health Law and Policy, ILS Pune. Dr. Sunita Bandewar ji, Director Health Ethics and Law Institute for Training Research and Advocacy, HEAL Institute. The conveners of the program are Dr. Simi Mehta ji, Dr. Arjun Kumar ji. To begin today's discussion, I'm honored to invite Dr. Amar Jesani ji, Chair and Moderator, to share his opening remarks. We welcome you and over to you, sir.
Thank you and good afternoon. As a person working in the field of bioethics, my first encounter with the discipline was about discussion on the beginning of life and end of life. I realized that if I want to do something long term in bioethics, I will have to look at the issues of the beginning and end of life care as much as possible, because they are not just medical issues, they are also social and ethical issues in a big way. Particularly, issues related to things like abortion, things like euthanasia. It's not just an interaction between doctor and the patient to decide what is to be done, but there is also always a third party in the room, sometimes present, sometimes absent, but always there. Physically not there, but always, exerting influence. It may be morality of the society, it may be the law of the of the state. That will keep coming in the way of what the health provider does to the request about the end of life or about the termination of life or termination of fetus in the case of abortion. So these issues are that way very, very complex. There is no easy answer to it. When we discuss about end of life, we realize that to have a webinar on all aspects of the end of life care will be very, very difficult because there are so many issues involved there. We start with what is the end point of various diseases that the person in the end suffers. The kind of medical care and technologies that have emerged has changed the end of disease scenario completely. When I was a medical student in 1970, for me, having a patient with a liver failure or the kidney, we were able to give some palliatives and wait for the person to die. There was not much we were able to do. Then came dialysis, it became so prevalent. It was already discovered when I was a student in 70s, but it was not available in the public hospital where I studied. But gradually it became available. So you have that came, then the kidney transplantation, same way for the liver transplantation and all kind of new technologies. Change that what could be the end stage of a disease. So that is a vast area of discussion. How to deploy those technologies, who gets, who doesn't get, what are the ethical challenges. In fact, bioethics in USA emerged from the debate related to how to ration this technology among the patients who require it. Today we have technologies available and we don't know how it is being rationed in the country. We discuss about organ transplantation. But there are people who give the organs and people who receive the organs, their socioeconomic characteristics are so different. And every few years we have scandals about organ trade, despite having a very strong law which does not allow us to do that. So these are the vast number of area, and palliative care is another one. So we could not go into all of them, but we realize that there is one area where there seems to be a lot of work being carried out, and there may be some ray of hope of things changing. Is the area where what do we do where a patient has no future, is in the terminal illness, and all assessments of medicine says that person will not survive, and there will be very, very low level of the quality of life in that case, and the person wants to go as peacefully as possible. What could one do in that such situation? So that's how we have focused this discussion on issues related to withdrawing the life support system, where person is either in the terminal phase or almost dead or is brain dead. On the other hand, we also have a situation where many countries have liberalized law to allow the medicines to assist people who would like to have death before the terminal illness consumes them. So they would like to decide how and when to go because there is no hope of their survival in the short or medium term because of the disease they are suffering from. And this area is also very, very important for a country like India as compared to, say, countries like, say, Canada, where there is a hotly debated issue where they have made, medically assisted death law. And still, where the Canada is a universally access healthcare services. And you don't have to be a rich person to access, the supportive care in the terminal illnesses. And yet they are allowing it. While in India, we don't have that kind of universal access. And in such a situation, what kind of law that could be framed where we can definitely help patients who are in the terminal phase and would like to get assistance from medicine to go or end their life, and yet ensure that those provisions don't get misused, and because of the strong dominance of the market in the healthcare services in India. In addition to that, our regulatory mechanism is very, very weak. The ethics regulation of the doctors are extremely weak. Even the National Medical Commission and the state level medical councils are not able to regulate medical colleges. There are a lot of controversies keep coming about them. Now, to regulate the individual doctors' practices when we have got 1.5 million doctors in the country, without having a good infrastructure for regulation and, of course, good budget for regulatory mechanism is going to be extremely difficult. So there is a, in the absence of such regulation, people talk about the misuse, and that is one of the reason I think our lawmakers and the judiciary show some reluctance to liberalize the law on this count. We have to find a way out because on one hand, there are suffering patients who are having a desire to be helped, and at the last phase of life. But personally, I would definitely prefer to have that kind of help from, my medical colleagues because one doesn't want to unnecessarily suffer when you know that you are not going to recover from the problem that you are suffering from. So we did need a mechanism to be established. So we had to look at both medical challenges, social challenges, and how the law should be responding, and what is the current status of the law. And there are uh, cases in the highest, echelon of judiciary, Supreme Court, on this being decided. So I think it will be very timely if we are able to come out with some suggestions to be circulated to the policymakers. So with this background, what we will do is that we will start with medicine because that is where the entire thing plays out first. The patient in the last phase is there in the hospital, and there are doctors and nurses and other providers who are trying to help the patient, but they realize that there is a futility of everything that they are doing because this is too commanding, and that's where decision has to be taken when the patients or patient's relatives, the patient is unconscious, then the relatives, or the patient has made a living will, then the doctor and the hospital have a duty to decide what to do there. So we start with that where Dr. Kaustubh Joag is with us, who is from medicine, and she is also a psychiatrist, so he should be able to bring all the mental health issues to there. And then we'll go to the other side, the demand side, the consumer side, that is the patient side, where we have Sunita Bandewar, who is an anthropologist and also a bioethicist, and my colleague in the Indian Journal of Medical Ethics. And what are the society's expectations? What kind of safeguard society would like to have, and whether there is any possibility of working on the moral framework of society about how to look at the death and how to allow people to 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 have the death in as painless manner as possible in this kind of situation. And then we'll go to Dr. Dhvani Mehta, who is not just a lawyer, but who is also involved in helping the policymakers to draft laws. And she is involved in drafting a law around this issue. So we will have more things coming out about what is happening in the court, what is the law status, and how she is and her colleagues and other people are jointly trying to do advocacy to make changes in the policies in the law. So we start with Dr. Kaustubh Joag, and do you have a PowerPoint? Then you can start sharing now, and you have about maximum 20 minutes so that we have half an hour for discussion. Okay, thank you.
Thank you, Dr. Amar. Thank you very much. I don't have a PowerPoint. I have just, because I have a lot of thoughts around this topic. So I also thought this is more conversational rather than, because at the outset, I'm not like an expert in this topic. I'm talking from different hats, basically being a doctor, then now being a psychiatrist, worked in the hospital in the intensive care settings. And obviously in last 15, 16 years now, I'm studying human rights of people with disabilities. So so I'm also talking from that rights perspective and some bit of it, the ethics perspective, because so first, I think I would like to thank for inviting me for Impact and Policy Research Institute. Thank you for having me here. and sharing my thoughts. I think when I was I think reading about this, not now from the past also, and the real life circumstances, like one of my close relative recently made a living will about withdrawal of medical assistance when they are going to be at the last stage. So we actually made it like a legal document and signed it, and that's a different perspective as a person who's one of the close relative is making that kind of a document. Many thoughts going into my mind. So I will try to stepping back, I'll try to make it more from, as Amar has said, from a doctor's perspective, from health professionals' perspective. And also another major stakeholder in this case is the nursing staff, which is, the very close to the any kind of a care for people with terminal illness. And lastly, I would like to also highlight on some aspect from the psychiatrist point of view, because there is a debate between whether there is an element of depression or element of hopelessness, which kind of creeps in when people go through terminal illnesses. Particularly, there are studies in cases of cancer where people do go through depression, and whether depression then makes them helpless and hopeless to take that decision of going through or will to death, basically, or will of dying. Sorry. So that's, I think, my last point. At the outset, one more point additionally I want to make. When you said, Amar, about the doctors and the other perspectives, I think, unfortunately, I think, at least for me, my own personal experience learning is, unfortunately, in the medical training, we have never exposed to the training of ethics, training of law, training of rights. And I think that has a huge gap between when we talk about, the social and the patient's perspectives and the rights of patients. I think there is always this training gap, which is always, at least I identified, because when I trained as a medical doctor and as a psychiatrist, never there was any discussion around rights and ethics. So I think that's, I'm trying to say, when I come from a doctor's perspective, I think all of you listening need to understand that lack of training also is important part. And we should not see dichotomies, or we should not see doctors as a separate stakeholders and the patient and caregivers as a separate stakeholders. That's my limited point. So I think going ahead, my first point of the discussion is largely, there was, I think, if some of you already know, as a doctor, we are bounded by what we call as a medical ethics, or in the past, it's still there, I think, Hippocratic Oath. Hippocratic Oath, famously based on the premise that make no harm, basically, or do no harm. And then the premise is also from the what is the best interest of the patient, basically. So these are the two principles with which I think the doctors or the health professionals, or the people who are providing any kind of a treatment largely in the hospital settings I'm talking about, are bounded by. And now, when we talk about medical assistance withdrawal, or of euthanasia, or this physician-assisted suicide, or medical assisted, death, then I think it does cause a lot of dilemma and conflict in the minds of doctors and the health professionals. Largely, the dilemma is of twofold. I think one, obviously, principally, because if my professional ethics told me that I should not do any harm, and my role as a doctor has to save lives of people and care for people, and obviously give them a better quality of life, then how can I assist them with the death? So it's what I'm trying to say, this is contradictory, and that does create a conflict in people's mind, largely the doctor's mind, as well as the the nursing staff, or the hospital staff, or the health workers in general. So that's one, I think, one point I want to highlight, this conflict. Why I'm saying this conflict is that then puts on this issue about the disease and the prognosis of the disease, and whether this is the kind of a end of a care kind of a thing, and there is no more care available for this person. And this I'm talking about because I have studied in a rural medical college, and where there were limited there were limited facilities available for any kind of a terminal illnesses. I think what I'm trying to say is that there are disparities in the health system in India, and what you get in the cities like Bombay and Delhi, that kind of medical assistance you may not get at the rural India where if you go. Now, in their from their mindset, when I discuss these topics, most of the things, then what happens is, whether as a doctor I'm providing the complete cure or completely, whatever is available to the patient basically, and if not, then how can I, again take this decision, or not I am taking as a doctor decision, but at least advising family to stop the any kind of a medical assistance. So that's another point, limited point, but that's important point, because yes, there are many diseases like neurodegenerative diseases like motor neuron disease or cancer, some terminal cancers, where most of we have a common, kind of understanding that it is inevitable, and then the death is inevitable. But there are many other diseases where that's not the case, and if you continue to provide medical support, then the life will be prolonged. Obviously, when I'm talking all about this, I am the other part of the story is the suffering, basically the suffering which person or the patient goes through when they are going through all this through this technology. As Dr. Amar has said, we have advancement of technology, so we have all the machines now supporting the life, but actual suffering of that person when they go through this life support, that's completely the kind of a different angle or perspective when we talk about even the providing life support from a doctor's point of view. So for me, I think doctors and the nursing staff, particularly whatever I have seen in my limited last 20 25 years of practice or a clinic hospital based practice, is that there is a lot of this dilemma and challenges around how they can take this stance and how they can support the death, basically, because their day-to-day job is to save lives. So that's I think one point I wanted to highlight. The moving ahead with this, I think beyond this, the doctors say the other important point I wanted to mention, and this is more from, I think, as I said, nursing staff point of view, particularly when there are patients who remain in the hospital, and there's again these people with terminal illness, like I think we just said about Aruna Shanbag's case in KM Hospital. It's a famous case. When people are there for months or years, then what happens, whatever said and done, what happens is there is attachment between the patient and the staff, basically. And that attachment, I think, is, that attachment, when I say, is the emotional attachment. So, and you can't have a very clear boundaries and keep your professional, like a professional ethics intact. So what happens, whatever said and done, the doctor, or more, as I said, nursing staff gets involved with the patient's care. And that generates a lot of hope in the minds of doctors as well as in the nursing staff, that they should try and continue to try, and not let patient die, basically. So I think that also is another dilemma, particularly in the when there are like people with the brain death, basically, and they are in coma, and if they are there for years together, then there is a lot of that attachment which happens. And then there are cases where some of the people have, after years, they have came out of coma and kind of lived their life afterwards, like if people have seen Munna Bhai MBBS, there was that case where one of the person who was in coma, suddenly after many years came to life. So what I'm trying to say is, this hope or this kind of a cases then keeps in doctors and medical professionals' mind, if I'm taking this right decision when I'm, assisting somebody from death. So these are I think, two important, I would say, the points from a medical professional's point of view. I wanted to highlight. The third point I thought was, who may we say this, the medical assisted death or dying, or physician assisted suicide. I think there are different terms used internationally. But at the end, obviously, when we talk, the other side of the story is the patient's rights, autonomy, choice, and free will, and obviously that needs to be respected. So, but when particularly in the cases where people have lost their capacity, or they are unconscious, or they are in coma, What point I'm trying to make is the reality is many family members or caregivers rely on doctor's decision at the end of the day. So at the end of the day, they, as a family or a caregiver, most of the time, even if they think that this is the right decision of withdrawing medical assistance, but at the end of the day, they rely on the doctors to take that decisions. And that's the reality, in India also, that most of the decisions are made by the doctors basically, or suggested by the doctors. And people are not, I think, culturally, I would say, or overall, maybe from a kind of that concept of autonomy and autonomy and personhood, we are not like that community or culture which we take our own decisions. So somewhere I think that decision making lies with whom. Why I'm bringing this point, because then the last point which has been made by Dr. Amar also, ki if obviously we get this law and this becomes a law, then there is a potential misuse of it, because if you have doctors to make these decisions, and if there are, again, we know that the regulatory mechanism is very poor in our country, particularly for the medical doctors. I also had this case in mind about the organ transplantation and donation. Every time there are scams, there are many other issues. So how do we then, who then takes the decision? I think that's going to become more important. Even if on paper you say that patient will make decision through living will or through, any advance directives, or caregivers will make decision, but at the end of the day, in reality, doctor will be part of that decision. So I think what I'm trying to touch upon is also, without any regulatory mechanisms and without any proper monitoring on this issue, giving this decision-making power to only medical professional may have its other side also. So that's a limited point. The last, I think fourth or second last point I wanted to mention is now more from a psychiatrist point of view. And as I said earlier, at least in my own experience, I have worked closely with the oncology department, and for some time I worked with the palliative care in Pune. In Pune, there is a Cipla palliative care. So for some time I worked with them. So largely, again, I'm coming from the overall, the evidence suggests that there is a high level of depression in many of the people who have terminal illnesses. And now, how do you separate, as I said earlier, the depression and depression causing thoughts of death, and kind of a real thought of a death? There is if I'm making a sense, there is a difference between these two, because as a psychiatrist, I would try to cure people from depression, or get, for thoughts of suicide for us is symptom of depression. I'm just talking from a clinical point of view. I understand the social perspective and the person who is suffering, but at the end of the day, as a psychiatrist, we will try to treat as much as possible, either through medications, counseling, therapy, or any other support. These thoughts of death, which in a psychiatric term, these are the suicidal or self-harm thoughts. So that's another, as a psychiatrist, that becomes a dilemma. So I still remember, one of the case when I was training in psychiatry, there was in the hospital, there was one person. I studied in the armed forces. So there was this young person who, unfortunately, I think that IED blast, or the I don't remember the term, but the blast basically as a soldier, and he lost his two legs and two hands. So practically, he completely lost his hope. Now one can say that. And he is from a lower socioeconomic strata. So one can say that he had a depression. That's why he got to our hospital. We should, as a psychiatrist, I should treat him and cure his depression and cure, his thoughts of dying. But at the same time, he continues to, and he remained with us for almost 1.5 years. Every day he continued to wish, he wished to die basically, and he said there is no hope. Basically, there is nothing in his life, because the lower socio, because he is from a lower socioeconomic strata, there was no money in the family. They can't provide him with the assistance with his any kind of assisted walking or for his hands. He has three sisters in his house, and so on and so forth, and his father is no more. So whether my point is whether you take this as a clinical depression or whether you look at the social side of this person, and whether then who will make this judgment, whether then psychiatrists will make this judgment that this is not a depression and this is the cure for depression we should stop, and then let the person do. Because then there is a huge another this another debate in the psychiatric circle, at least, is also about the suicide. Because and this is the case of I was saying, there is a death wish of death that person was saying, in clinical terms it's a suicide, but in many cases it's really that people do not have a choice basically to live. There was no other for them, there is no motivation to live. That's my point, limited point. Coming back to this, as a psychiatrist in the terminal illnesses, just for kind of whatever I have read about this topic and the papers basically. So as I said, there is a high evidence, high prevalence, almost 25 to 30% depression. So what we also have to look at, if and that I have seen in my personal practice also, if we really treat depression properly, and obviously there is some form of assisted, either a palliative care or either any medical assistance is given, then the quality of life improves. What I'm trying to say is, many a times depression becomes a barrier, or depression become kind of a factor in causing a poor quality of life along with the terminal illness, and that compounds this wish of dying more and more. So if you actually remove the depression, there is a possibility that the thought about dying may also reduce. So that's one aspect I think I just want to highlight. Again, these points which I am mentioning are, I know every point has a two sides, so I'm not trying to take one side of it, but these are the points whenever I read about the literature about this and my own thoughts about it. I think the last point I have to make, and again from legally, I think we have to make this more stronger, as I already touched upon. But this issue around the capacity is always an issue, and who decides the capacity, and this debate about who basically, when I say capacity, is a decision making capacity, and when even you are making a living will, have you basically, it's an informed decision, or is it taken with the influence of somebody? So that kind of a capacity, and plus obviously capacity when you are having a neurodegenerative condition. Again, as a psychiatrist, we face this challenge in persons with dementia, where we know that this is a neurodegenerative disease, and there is nothing to happen. We do not have any form of a treatment other than a palliative basically care or assisted care for people with dementia. But if that person has not written anything and they have lost the capacity to decide, then who basically decides on their behalf? And from a mental health perspective, now with new Mental Health Care Act, we have a concept of a nominated representative. So it's a nominated representative who will, decide about take a decision about when person loses their capacity, even in cases of dementia. The problem, what I'm trying to say here is, the law is there in India since 2017, but it is still not implemented at all. So the problem is, even if the law is there, most of the patients do not know that there is this concept of nominated representative, and then the guardianship, which was earlier a substituted decision making, has now no more into force. So again, the issue is this implementation. Even if, again, I'll finish my talk in 2 minutes, but issue for me is, even if we are talking about the assisted deaths or assisted dying and making this as a law, the issue will be of a implementation and how far we are going to implement it. And then the last issue is of a monitoring, because the same issue happening in psychiatry currently, that even if we have the new law with all the rights given to the patients, as well as the largely to the patients basically and premise is obviously the Convention on Rights with Persons with Disabilities, and premise is autonomy, free will and choice. But the issue is of a monitoring, so that there is a so poor monitoring of the law that I see there are day in and day out, I see the rights violations happening in psychiatric institutes and hospitals. So my always worry is, with any law which is coming, for the benefit of people, many a times it does not reach to those people who are really in need. And again, because we have a disparities due to the urbanization, due to the economy, only few people will avail, the that provisions of those law. So I think that's my last point. But in nutshell, I feel from my own perspective, I think I always, man, again, as I said, because I've been student of rights and I've continue to understand the rights perspective basically for people who are actually suffering. From my point of view, this is an important topic and this is a very, very important subject that we should push for. And these all concepts of, whether you call it medical assistance death or withdrawal of medical assistance is there in India, but actual medical assisted death should be that this choice should be given to the patient, I think. And if they know that this choice is there, then they can put this in the living will, or they can have what we call as advance directives, and that should be respected. And ultimately, as we say that it's all about dignity and respect. So if life is all about dignity and respect, so death is also should be all about dignity and respect. So that's where I think my thought is. So thank you very much again. I hope I have been on time, but thank you for giving me opportunity sharing my thoughts on this topic. Back to you, Dr.
Thank you, Dr. Joag. I think it was excellent because you touch upon all the complex issues and provided a very nuanced understanding. And I could see the influence of the rights-based approach in your work, because as you say that when we are trained as doctors, we do learn little bit about our duties, that what are our duties to the patient. But then the rights are to be, balanced with the duties. Then we start struggling. And since we are not exposed to human rights perspective as much during our training, we have this dilemma all the time. And in a way, and I try to talk about ethical duties flowing from the human rights, because ultimately, when we respect autonomy, we are actually respecting the human rights of the patient. So that is where it is. But here, in this concrete situation, as you said, and how do we judge what is the best for the patient? Or we just allow the patient alone to judge, and the doctor has no agency to, have a deliberation with the patient on this subject? Or do I, as a doctor, as you said, that you have to also look at why patient is asking for what he or she is asking for? Is it because of the socio-economic condition? You took talked about a case study that where you yourself was wondering whether it was a case of depression or a case of depression caused by the social background of the patient and the demands the society was making, and that was one of the reasons why the patient was repeatedly thinking about death. As you realize, I mean, it's very difficult to make a judgment because what comes from what, whether the social crisis causes depression or the depression is leading to the social crisis. Anyway, but it is really quite illuminating for me, and your emphasis on the regulation, monitoring, things not working at the ground level, where our regulators are not able to reach out and really do the good monitoring, is very important. That means that every institutions where doctors practice, including small clinics where they are, there has to be a good regulatory mechanism, and which also should involve society to such an extent, so that there are no doubts about what doctors are doing. And particularly, you and I would agree that we as doctors won't want to be seen as a messenger of death. We are actually there to save the lives. And that's why whenever doctors get involved in anything which is related to the death or encouraging death, people start feeling uneasy that is my doctor involved in encouraging death, then perhaps he is not the right doctor for me. So yes, I think these are the dilemmas were very, very real. And so we go to now Sunita. Sunita, I think you have a lot to even start from what Dr. Kaustubh said, that family dynamics are also not just about psychology and mental health. They are also power relationship within families, and families are not always good to the patient. So that, I think that is where I would like Sunita to come and step in and talk about the social and other moral aspects of the society impinging upon this issue. Yes, Sunita, please go ahead.
Okay, thank you. Thank you, Amar and Kaustubh. That was, you have already set the stage. There's likely to be some overlap across the three talks, and I don't have slides, but I've also have written my talk just so that I stay focused and streamlined. I just want to kind of pick up on a couple of points that that really come up very prominently from both what Amar said right at the outset and his rebuttal or kind of, a comment on Kaustubh, your talk. And that's really, the one is the power dynamics amongst the different players, and which sort of, we in general conversation, I don't think that's generally is kind of, talked about. So that is one thing that I sort of, it also will come in my the points that I'm trying to raise. And the other thing is, very important point you raised is whatever legislative frameworks we make and the policies that we bring forth in country like India, the implementation gap is a huge problem. I don't think anybody has been able to address that satisfactorily enough. So there is really a legacy of very progressive legislation that we have, at least in certain certain issues or certain matters. And for example, as you mentioned about the Mental Health Act, I would also say that the Abortion Act or the MTP Act, we have PCPNDT Act. There are several. We have we've been constantly dealing with the gender-based violence, and we have the legal reforms. Absolutely, kind of, we have experienced paradigm shift in the criminal law amendment of 2013, post Nirbhaya case. And to my mind, that has been all contribution of the long-standing work in case of the GBV or the gender-based violence related matter. It is a lot of credit goes to the sustained efforts by the women's movement and the feminist movement that contributed to the discourse on the basic concepts. So in case of the gender-based violence, the definitions of rape, sexual assault have been kind of, undergone changes. And the point I'm trying to make is these are fairly progressive laws and legislative frameworks, and yet the ground realities are very disappointing. And that's sort of, one is about the implementation gap, but there's also something about lack of political will. And increasingly, the judiciary also is getting affected with the political interference. So with that, the challenges are actually, they just look so daunting that we can't really, to me, it looks like often hopeless if there is a political interference and the judiciary is compromised, which is the last resort for many of us, like all of us. And so if that happens, it is sort of, completely compromised healthcare. And this happens also in the healthcare system spaces. So I just want to flag those implementation gap issues and sort of, fairly uphill task to make sure that the laws really, if there is a law on this that is complied with, and then there's a good implementation of that. So with that, I just wanted to say also thanks to the organizers to have this opportunity. And as Amar has already pointed out, that I'm mandated to briefly talk about and lay out the socio-cultural and ethical aspects of the issue at hand. And so I would like to begin. I have a couple of stories weaved into this talk, and I would like to begin with one of the stories. Once again, Amar made a reference to the medical. It's called MAID, the medical assisted dying in Canada. and we have a common friend. We have a common friend there in Canada. As all of us know, medically assisted death related issues are much complex. And although the withdrawal of life support and the assisted death are related, I think there's sort of, there's some kind of markers which kind of make them different, and the issues are there for different. So I treat them as conceptually, they are sort of slightly different categories. And the assisted death as a conceptual category has a somewhat wider scope, at least going by the current practices elsewhere in the Western world, which are governed by the legal frameworks. And we know most of the, I wouldn't say most, but we know some of the European countries, Canada, and now the UK also has passed these legislative frameworks. And so I have had this friend in Toronto. He was about 76-year old at the time of his choice when he sought or applied for the assisted death, which is legally available choice for citizens of Canada. And it's a sort of, they are still kind of learning from that legislative framework because it's fairly a new development. I think it's about 10 years now since they have the law there. He sought assisted dying on the basis of some of the outcome of the diagnostic that he undertook at that point in time, which were related to the cardiac health. And there was also kind of doctor had some kind of assessment on which he said there's a likelihood of he getting there's a possibility of stroke that he might suffer from in the subsequent times. And with that, I think he just decided to seriously kind of consider the option. He was really hell and hearty at that point in time. His application was scrutinized and fairly stringent kind of procedures. And this is all first-hand information because we were friends at one point in time. We had sort of, shared the apartment when I lived in Toronto. So we've sort of, have been in touch for all those years, 20 years of kind of friendship that we shared. So it underwent the scrutiny, and his application for the assisted dying was approved after due processes were followed. This was 6 months period. That is kind of a period where people can really revisit their idea of idea or their choice for going for it. And so at the time of application and 6 months later, at the time of the authorized doctors executing the procedure of assisted dying, he was on his own, independent, hale and hearty. And to me, it came to when he informed me, and he really reached out to many of his friends, both in Canada and outside, telling us about his decision. And it came to me, well, it was quite, in a way, shocking. I felt it was a very bold decision. I sort of always remembered him as a very strong person in terms of also his health, etc. And his approach is something that I took some time to reconcile with. And yet, this is what many of us would prefer if we have a choice to choose when to die. And sort of, I think both of you have pointed out on the aspects such as dignity, ability to use one's agency. I think this was something, I thought it was a dream death in a way. We lost him as a friend, but at the same time, he was very happy. He really managed to meet several of his friends. He planned in a way his 6 months after the decision came in as what all things that he would like to do. All of us, we know that this, what is it called? The checklist or the basket that you want to really tick mark that you've not been able to do, etc., etc. And the other thing that both of you have been highlighting is the when is this possible? It is possible because he didn't have to worry about the socioeconomics and the other constraints. And this is possible when there is a universal healthcare is sort of, is available to everyone, and people are secure, there is a health insurance available. And so it really makes the larger, broader context a difference to how people arrive at this decision and how these decisions are implemented. Does that mean that there are no issues in Canada and elsewhere wherever this law exists, or sort of fairly robust legal framework exists? I would say that's not the case. I mean, there are still problems. If you look at the ethics literature coming from those countries after the implementation or the kind of passing of these bills, there are problems and there are also risks. But yet I think the broader context enabled fairly just and judicious implementation of this act. So I just wanted to put this out as a story to say that these are possible scenarios, and we all would aspire that India would sometime reach there. So I just wanted to say this might be called as Ichhamaran or the willful death, which was medically assisted. And India as well, we have been sort of witnessing long-standing conversation around Ichhamaran or the willful death. And so sort of even if it's not taken the shape of public discourse, I would also like to mention that there's some kind of a contradiction in the way we look at the sort of we understand the broader context, where there's so much written in the scriptures across probably the faiths, but definitely in the religions like Hindu and Jainism, and I'm going to make mention of a couple of things there. But in the public spaces, in the public discourse, we really don't like to talk about death. So once again, a just brief point that I want to make here, just for those who are interested. In many countries outside of sort of I would say Europe and the Western world, there are death cafes. So cafes. So basically, those who are interested to talk about death, they want to talk about how they would like to die. So there are groups who come together and talk about it. And so I think it's kind of very contradictory in our context that we are dreaded. We also feel it's a bad omen. If somebody talks about one's own death, saying that, I might die and I have to make these arrangements, just making simple wills, our own wills, and so that, things are in better shape after we sort of die. People just say, please don't talk about your death, or it's not good to hear about it. So that's the kind of taboo around the death, and I think it's quite a major obstacle to talk about death and sort of the assisted dying, because the conversation really doesn't go ahead. So these are the sort of if we are wanting to put in place the DNR, the advanced directives, etc., for those documents to take shape and receive some kind of acceptance at the society level, we really need to be open about talking about that. If that doesn't happen, the DNR advanced directives would remain to some kind of sections of population. To my mind, it remains kind of an elite kind of a culture that some people would get into that, get it done. And then, of course, there are a lot of implementation problem. So coming back to these practices, I just wanted to mention there's something called Salekhana and Santhara that is followed in Jainism. And there's also a practice called Prayopavesh, which is kind of practiced in Hindu faith. And there are at least sections of people from networks like us that are advocating for creating safe ecosystem, which will enable individuals to choose these methods and ensure minimizing foul plays. We've heard some of the thoughts about how these kind of systems can have inherent risk of murdering people if there's somebody who wants to eliminate the person that is being the concerned person. So Santhara or the Salekhana or the Prayopavesh seems like they're fairly robust systems. And they're transparent because there's a lot of community involvement in this decision when the individual starts thinking about it. There's also family consultation. So there's a fair bit of transparency in when people arrive at these decisions, and the way these kind of, the activity around Santhara or Salekhana is take shape. And it's basically you stop consuming food and stop drinking water, etc. And so that's the method that is followed in this thing. So I just want to raise a couple of issues here and mention the pluses of these systems. In these cases, the person uses one's own agency and chooses to die with dignity. And I think that's very important. However, these practices are not legally supported, and there have been cases in 2015-16 when we were doing the conference on the theme of end-of-life care and palliative care. And this was a very hotly debated or very intensely debated the petitions in the Supreme Court of India. And they actually sort of, the verdict were against these practices. So these are not legally supported methods. Well, there could be sort of, instances of this happening without the notice of the government or the legislature, etc., etc. So that stands. But does that sound logical on the face of the fact that Western world has progressed in legalizing medically assisted dying? Is there a different approach to engaging with these issues as connected ones so that there is a consistent ethical and legal position on these matters when we start thinking of medically assisted dying? So I just wanted to put that story out and also talk about these two practices in India, fairly grounded in our traditional thinking. I just want to kind of also alert everyone. There's also practice called Thalai Kuthal, which is sort of, does not take into, and this, I just want to kind of explicitly mention, this is not same as the Santhara or Prayopavesh. And this is simply because this is, in a way, there's a science behind it, but the kind of documentation that I have come across, which says that the families choose to fall back on this practice in absence of the wherewithal to look after their loved ones because of the circumstantial constraints. So basically, lack of resources to look after your old ailing persons or young ailing persons are basically people who are not sort of, don't have the, and this is deeply rooted into the inequities, really sort of, both the basically economic inequities, but rooted also to the structural kind of issues because they go hand in hand. This completely violates the agency of the person and amounts to murdering the person. So I just want to really make sure that we understand these practices in a right way. Some of the points that I'm going to talk about, and I have one more story there, is really goes back to the stakeholders that are involved into the end of life care or any healthcare setting. So, Kaustubh, you rightly pointed out, we have patients and their significant others, which could be family, friends, and beyond, but basically are important for the patients and the treating team. I would also include the health administration, and when I say treating team, which also includes the nurses, which has been underscored by Kaustubh. So we need to also locate social and allied aspects involved in the issue at hand in the context of the broader healthcare ecosystem. And, some of those issues have been raised earlier, but I still want to kind of, sort of take this forward. So as most of us know, this ecosystem is characterized by healthcare system and the way it is organized with dominance of the private healthcare sector. Once again, this has been said earlier, with little regulation and increasing trends of corporatization of the healthcare system. The increasing healthcare cost and the devastating widening disparities among those who can afford the quality care and those who cannot. So this is the broader ecosystem in which we are talking about the sort of, ethics or socio-cultural aspects of the withdrawal of the life support. In this, once again, we've been talking about, we want to center stage two concept. One is the dignity, and the other one, which is somewhat less talked about, is the best interest of the care receiver. And so when Kaustubh was talking about the dilemma that sort of, many doctors or every doctor would face when they take the Hippocratic oath and they have to really deal with this situation, I do think that the one of the ways to frame that dilemma or navigate through that dilemma is to center stage the best interest of the patient. And I think that will be somewhat make it easier to navigate through that dilemma. And I know it's not kind of black and white, but I think to me it will make things one can navigate through it somewhat more smoothly if we center stage the best interest of the patient. And this doesn't mean to not acknowledge many other kind of complexities and some that have been already stated. Economics of care is not just about money matters required for the medical care, but it involves who provides care, at what cost at the level of individuals within the family and the close ones, how it impacts families during the care and beyond, and how gender, economic status would play out in deciding, in deciding how to go about, even from the family perspective, how do we really decide start thinking about withdrawal of the life support, or what could be the regime for the end of life care, etc., etc. And so this is how the socio-cultural issues are closely interfacing with the economics of care. And if things fail on one count, it is a way to slip into a vicious cycle of compromised care and care decision for the patient. So once again, that's if we take that into account and use these kind of or even appreciate the complexities and the close connections between lack of universal care, the way the healthcare system is organized, and how the economics of care are closely related with the other aspects of the social aspects. And I think gender is very important, and there's a lot of literature outside, but in Indian context, there are some conversations around it. And I think we had a chance to discuss and center stage gender when we had the 2017 conference on this thematic. So I'm going to share one story here. And this is a first-hand narrative which tells us the intricacies and far-reaching impact on caregiving families. So this is a case of two women, and I have witnessed this, who have been providing home-based care to their mother in permanent vegetative state. This was going on for 13 years when I met them, which was quite some time ago. And one of the women was just in her early 20s, or let me say one of the daughters. And both sisters, although employed, decided not to marry as it meant leaving their mother unattended. Of course, needless to mention that their father expressed deep sense of guilt during that kind of, speak outs that I was part of, for being responsible for his daughter's inability or decision to not marry. So this also indicates the gendered nature of caregiving in families and the complexities and the adversities involved therein. So would this scenario be different if India had a better public health and social care system, had access to universal health care? Would legislation of advance directives make a difference to this situation? And what if the family had no daughters and only sons? These real life scenarios pose challenges that are beyond medical sciences and are difficult to resolve, since they are rooted in the structural inequities, including patriarchal families, the social structures which are disadvantages to women. I just want to highlight the gender aspect of the care. And I just take this opportunity to and take half a minute to say that in the care spaces, both in the healthcare system, like the formal healthcare system, and the informal, which is basically the home-based care, women always have been fronting the care. So even if it is, I'm not even talking just about the nurses. The nurses in the current context, we are seeing the trend of male nurses coming in, etc., etc. But even in the healthcare setting, just because if you look at the public healthcare system, it is a very usual practice that the family members provide care even within the healthcare setting, leave alone looking after the patients at the when they're brought home. So gender really plays out, and it's kind of, we can't really not talk about how our families are structured and where women are placed in those familiar structures. And it's very important, and it plays a big role even in how one looks at the decision making of the withdrawal of the life support. I just wanted to kind of say a few things here about the empirical evidence, and there's empirical evidence that demonstrate that decisions to withdraw life support is determined by the purchasing capacity of families or patients rather than the medical prognosis or the medical sciences there. And so there's also enough evidence that in the corporatized medical world, ICU admissions and life support is prolonged despite poor prognosis, because they can afford to keep the person as long as they want. So nothing can be more telling regarding the truth of inequity in healthcare access. So this is very disturbing, but these are the ground realities in country like us. This is definitely that we've been witnessing, and it's a paradox of futile care versus medically unwarranted hastening of dying. And there's little space to consider the basic constitutional right to autonomy of the persons, and right to life, and right to dignified dying.
Okay.
Amar, can I just take few minutes?
Oh, okay, but leave it in 2 minutes because we are already running late. Yeah.
Okay. So I just wanted to talk about the term terminal illness and how there's no kind of, it cannot be objectively defined. One is that the sort of, the modern medicine, when they have treated that or diagnosed or communicated to the families that it's a terminal illness, there are several cases around us where people, the patient and the family decide two things. Either they kind of, stop the modern medicine treatment and fall back on the alternative medicine, or they can take both the medicine in tandem. And there are instances, I have my own experiential knowledge in that patients have survived for not only months, for few years. And I think there was a there was a draft bill on the end of life care, and the terminal illness was included as a major term. Of course, they had to do that, but it was so vague, and there was a lot of critique about it. And so I just wanted to point that out. The other important aspect here is that if you look at the how the poorer people and the people who are located in the rural setup would define terminal illness, and that also comes from the context, and it becomes very subjective when you try to define terminal illness in absence of the wherewithal, resources, the equipped healthcare system, as opposed to the equipped healthcare system and families are better placed. And so that is another challenge there. Just one more point. So I think in the Northeast region, there are experiments done with the communication, mediation, and setting up some kind of training for the resident doctors. And they have had done the empirical work there to demonstrate that the communication and mediation with the families have improved the decision making, which is more patient-centered and which is more sound. So that's something that I wanted to highlight. And formalizing this communication and the debating on the ethics of these issues. I think clinical ethics committees is another approach, which I think India is not warmed up so far. So with that, I just wanted to say that, more dialogic approaches to the communication and engagement with different stakeholders is what would help us to take this discourse forward. And I think this has, at least I'm familiar with discourse for the last 20 years now. So there's a lot of work that has happened in India, but I think we need to have some more concrete steps that would help the larger sections of population or everyone who's faced with this situation. And probably Dhvani would help us with the insights from the perspective. Thank you.
Thank you, Sunita. I think you have brought so many issues on the table. And you have brought issues from the health services, about how the health services will be processing all these requests for termination from the patients or patients' relatives, and how complex is the problem within the services itself, both in terms of access, in terms of the power relationship. As we see in the transplantation issues, you have a live transplantation. You find that large number of women donate and large number of men receive the organ. So there is a gender disparity, there is a class disparity. I'm sure you will also have in mind caste and other disparities, coming up into play. On the other hand, you have also brought so many cultural aspects, and there is a lot of overlap between what is being talked about here as the terminal illness and the desire to die versus people's desire to die by suicide. Suicide is another prayer that I want to take my life. It's not that my life is not going to continue. I'm not having any disease. I'm not really suffering from a terminal illness, but my own social condition is such that I don't see my quality of my life good enough. So there are various cultural forms, religious forms that have emerged, some which are having overlap with what we are talking about, but some are about taking your life either for spiritual reason or for social reason. That is what is there. So all of them are on the table. I don't know how Dhvani is going to respond to it, because I don't know any policy or any law which can take care of such a big number of issues while providing some liberal support to patients and patients' relatives to make a judgment, to decide about when the life should be ending. But so I don't envy your task, but you are there for such a long time, so I'm sure you must have encountered all these issues, and you may have some good points on the subject. So, Dr. Dhvani, let us listen to you.
Sure. Thank you so much. And thank you to both Dr. Joag and Dr. Sunita for setting the context so beautifully. I don't have to explore all of these issues because they already have. And so the limited point that I will make is that not all of this can be addressed by the law. And I think that's the fundamental. I mean, sometimes that's the challenge. We do think that the law can have the answer to a lot of these problems. And while I'm a votary of the rights-based approach, both to healthcare and to other socio-economic rights, unless there are some system-wide changes, and here in this context, the two changes that I think are paramount and that both the other panelists have already highlighted is the need to have access to universal healthcare and the need to ensure that there are higher standards of ethics within the medical profession, as well as a wider curriculum that allows exposure to issues like this and a more nuanced understanding of medical ethics and especially best interests. So I think there is no legal reform that will be successful unless it is also accompanied by these kinds of systemic changes, and any advocacy that we do around this issue has to take in mind all of this, especially, as Dr. Sunita said, the financial reasons for withholding or withdrawing life-sustaining treatment. So it's incongruous to talk about autonomy and the right to die with dignity and the right to make an advanced medical directive, while also recognizing that there is a vast section of people that don't have access to that kind of care, either intensive care, critical care, or palliative care. So I just wanted to say that, we have tried in the past to ensure that, draft legislation or comments that are submitted on draft legislation that the government has proposed keeps these issues in mind. But again, I think after whatever experience we've had now working on this for the last decade or so, I do think that the law will not be able to solve for every problem. So having said that, there are some fundamental, I thought maybe I would just start off by making some aspects of the law very clear. And the only reason I'm repeating that is because it comes out so prominently in conversations that we have with medical professionals. So, whenever we do a workshop or a webinar with medical professionals, there are some basic questions that are often repeated. And so I think it's important to clarify what the law in India on this issue is. And by that, I mean both the withholding and withdrawal of life-sustaining treatment as well as assisted dying. So very simply, the former has been legalized and the latter has not. There is a tendency to refer to withholding and withdrawal as passive euthanasia. So people will recognize passive euthanasia as legal. But again, the accepted wisdom now is that that's not the appropriate term to use for this. And we've request that the term I think the Indian Council of Medical Research has also recommended that the term withholding and withdrawal or foregoing of life-sustaining treatment be used instead. Just a brief judicial history so that everybody is clear on where the law currently is. The legality of withholding or withdrawing life-sustaining treatment was first established in the Aruna Shanbag case. But at that time, there was a specific process that the Supreme Court laid down before which such withholding or withdrawal could take place. And that was that an application had to be made to the High Court every time a decision like this could be taken. This was modified in 2018 after the petition that was filed by the NGO Common Cause. And in that judgment, for the first time, of course, the judgment in Aruna Shanbag was confirmed by a bigger bench of the Supreme Court, and advanced medical directives were recognized as legally valid documents. This was important because previous Law Commission reports had repeatedly said that they should not be legalized because of a fear of misuse. So finally, they were recognized as legally valid documents, and the court laid down guidelines which replaced the process in Aruna Shanbag. So now we have a set of guidelines that apply in both scenarios of withholding and withdrawal, when there is an advanced medical directive and when there is not. So they apply to instances where a person lacks decision-making capacity. So again, a common misconception amongst medical professionals is that all cases of withholding and withdrawal have to go through the process that the court has laid down. But where a person has decision-making capacity and is able to refuse treatment there and then that is a decision that has to be respected without any further intervention. And the Supreme Court's detailed guidelines don't apply to such scenarios. They only apply when the patient doesn't have decision-making capacity. So these guidelines were initially laid down in 2018. They were, I think, not cognizant of the realities of how care is delivered or how decisions like this are taken in real time in critical care units. And so there was an application filed by the Indian Society of Critical Care Medicine to simplify these guidelines. And then these guidelines were finally modified again by a 5-judge bench of the court in 2023. So very simply, the guidelines that we currently have is that whenever you are withholding or withdrawing treatment, whether there is an advanced medical directive present or not, you require 6 medical experts essentially to sign off on this decision. And these medical experts are divided into a primary medical board and a secondary medical board. The primary medical board comprises the treating doctor and 2 subject experts. The secondary medical board comprises 1 doctor nominated by your district chief medical officer or equivalent and 2 other subject experts. But the doctors on both these boards have to be different. Fine. This also additionally, in addition to the opinion of these 2 boards, you also need the consent of either the person who has been nominated in your advanced medical directive, or if they are not, if you don't have a directive, then your next of kin or your next friend or your guardian. And once all of this is in place, then the hospital has to intimate the judicial magistrate of the concerned, who exercises the jurisdiction in that area, and withholding and withdrawal can take place. So this is where we are with the guidelines. And this is what the legal position currently is. The Supreme Court, as you are all aware, has just finished hearing a case involving the actual application of these guidelines to a person who has been in a permanent vegetative state for the last 13 years. So this is the first kind. I mean, there is. I won't get right now into why this case ended up in court in the first place. It needn't have, but it, for a number of reasons, it has come to court. But and just in the interests of full disclosure, I've been involved in drafting the application and appearing in court in this case. But yeah, we've been trying to reiterate to the court that there is a process that you have put in place, and we want that process to be followed in this particular instance as well. So I think what this case will do is demonstrate to medical practitioners and patients and caregivers that what the court had laid down theoretically can also be applied in practice. Sometimes that something is the law, but until you see it in action, it doesn't inspire the same kind of confidence amongst especially medical practitioners who, and I think I don't blame them, who rightly fear, legal liability and, worry about taking such important decisions without the seal of, either the court or any some other authoritative legal source. So I'm hopeful that what this judgment will do is demonstrate that this is what can be done, and this is the process that should be followed. I'm not by any means a votary of the process that the court has laid down. It's a complicated set of guidelines. It's perhaps it is difficult to implement in practice. It's not necessarily, I think they've been framed keeping in mind the resources that an urban tertiary care hospital might have, and not how healthcare is delivered in other contexts. But this is what happens when the court lays down guidelines or legislates. The court doesn't have a full picture of what the different realities are for the delivery of such care. It doesn't know the complexities of this kind of decision making. And unfortunately, then we are left with negotiation with these guidelines. So I'll come to the end, and at the end of my brief talk, I'll speak about what needs to be done in order to change or improve upon these guidelines, and how that has to happen with state governments and through state legislatures rather than through continued engagement with the court, because it's simply not the right forum to contemplate the different kinds of scenarios in which decisions like this have to be taken. So this is where we are with the law. The problem and the gray area that has currently arisen is because these guidelines that the court has laid down haven't been fully implemented. And the guidelines require action by state governments. They, at least in the context of advanced medical directives, they require state governments to nominate someone who will act as a custodian of these directives. In the context of setting up these secondary medical boards, they require the chief medical officer to nominate registered medical practitioners. This has happened only in Goa, Maharashtra, and Karnataka. Even in Maharashtra, the order doesn't extend to private hospitals, which ironically are the ones that do need this even more in order to, disincentivize them from continuing people on prolonged and unnecessary medical treatment. And Tamil Nadu and Odisha have set up committees to examine this question, but haven't currently framed guidelines. So in the rest of the country, in the absence of a secondary medical board, hospitals don't know what to do or are not motivated enough to approach the CMO and request the nomination of a medical practitioner. And so they usually throw their hands up and discharge a patient against medical advice. Or family members, again, for financial reasons or for other reasons, will recognize that, okay, there is no other way for me to get my patient out of this hospital other than to say I decline to give consent to medical treatment, in which case the hospital then has to allow them to be discharged. But the problem with this is that it means that a patient who would actually have benefited from palliative care and comfort care is left without any care at all. So the disproportionate medical treatment is discontinued, but what has to accompany it, the positive provision of palliative care, spiritual care, comfort care, is not provided. And this is often obviously a very distressing situation for caregivers to be then saddled with a decision where, it's a catch-22. They can't continue burdening their loved one with this kind of treatment, but they also have no provision of, they cannot ensure that their loved one passes away in a peaceful and dignified way. And so this is where obviously the need to integrate palliative medicine to ensure the positive delivery of palliative care services, to have a network of, say, home-based volunteers like you have in Kerala. These are all other policy questions that have to go side by side with questions around withholding and withdrawal. So these are some of the gray areas that doctors often ask me about. So what happens when somebody has not nominated a practitioner to the medical board? What happens for home-based care? Is a DNAR order valid? How do I, as a doctor, verify whether an advanced medical directive is authentic or not? What happens in an emergency room? What do I do when someone comes with an EMD to an ER? What about digital advanced medical directives? Are they valid or not? So these are the kinds of questions that have cropped up, and for which the Supreme Court hasn't thought about any of these issues. And these are not issues that are appropriately addressed by a court. As I said, these are questions that can only be answered by legislation, and legislation that is framed after consultation, after understanding what the reality of care provision on the ground is, after taking into account the different contexts and disparities in the provision of critical and palliative care. So all of this and all these different scenarios can be addressed only through comprehensive legislation. Even issues like who is authorized to provide consent on behalf of a patient. Now, just to give you an example, in the UK, there used to be something called parens patriae jurisdiction. So courts could act as a responsible parent and take decisions on behalf of patients who had lost their decision-making capacity. Now, that parens patriae jurisdiction of the courts was dissolved with the enactment of the Mental Capacity Act in the UK, which laid down a statutory standard of best interests for how decisions should be taken by doctors. And now there are, because 20 years since the enactment of that act, there is a long judicial history now of what best interests means. Does it mean putting yourself in the shoes of the patient? Does it mean only best medical interests? Or does it mean a wider set of social, other welfare considerations, other personal wishes and preferences of the patient? Are altruistic considerations a part of best interest? So there's a whole body of case law around this in the UK, but this has not developed in the same way in India yet. And so the understanding of best interest still needs to, we still need to ensure that what it means is actually a combination of this. Yes, a doctor must advance what they think is the clinically responsible medical opinion, but that should consider the wishes and values and preferences of the patient. It should take into account the opinion of their close, nominated healthcare representatives or caregivers. And this kind of holistic understanding of best interests is what should ultimately guide this decision. But our jurisprudence on this hasn't developed yet. And again, this is something that we can try and address through legislation in some way, although of course that will ultimately, of course, be interpreted by the courts. So this is where we currently are. I think it's perhaps it's best that I stop so that we can have more of a discussion around, if people have questions, we can save some time for that. Because I'm sorry, I'll have to leave in the next 10 minutes. My apologies for that.
Okay, thank you, Dr. Dhvani. I think you have narrated what we have and what are the limitations of what we have. I don't think I will like to summarize what you have said, because you are very, very clear in the presentation. I think I should give more time to the participants if they have any questions, so that all three of you can respond to the question. I think there was somebody who was trying to ask questions when Sunita was speaking. So please come over and raise your question either in the Q&A or directly talk to the panelists. Is there any question from audience? Oh, I thought in chat box somebody was raising some question.
Yes, sir. There are some comments, I think, from Akshara
Akshara
Nair.
Nair, I think she also raised hand in between. So I was wondering whether she is still there and would like to ask question.
Yes, sir, I'm still there.
Please go ahead and say what you want to say.
Sir, it wasn't a question, like it was just an answer when ma'am was discussing about the ritual of Santara that is practiced amongst the Jain community. I was just saying that, it was held as violative as Article 21, which guarantees right to life under Article 21 in Nikhil Soni versus Union of India. I have typed it, sir, in the chat box too. I was just raising the precedents.
Okay. I mean, what was the ground? Any idea why it was considered to be violative of Article 21? That is right to life, right?
Yes, sir. So the reason why they considered it violative was because here the life of the person was going away. Though it was a religious practice and customs are recognized by law, like customs are given legal recognition. But here, yes, ma'am.
No, I was just saying that I think that Rajasthan High Court decision was then stayed by the Supreme Court. So currently that practice is permitted, but I don't think the court has ruled on the, as in not gone into the legal question of validity of Santara or not. So as it stands now, that Rajasthan High Court judgment was stayed.
But essentially, Akshara bolo, yeah.
सर अभी भी मतलब उसका डिबेट चलता रहता है लाइक दो स्टे हो रखा है दिल्ली हाई कोर्ट सॉरी सुप्रीम कोर्ट हैज स्टेड द मैटर येट इट्स कंट्रोवर्शियल
I think this practice has more overlap with the suicide, isn't it? That you are trying to take your life.
Yes, sir. That's what the Rajasthan High Court has said.
Yeah, I think even in hunger strikers, when they go on hunger strike, the protesters to go on hunger strike, and the state intervenes to save them, and saying that, well, you cannot continue hunger strike simply because your health is being threatened by that, and doctors participate in force feeding of those people, putting Ryle's tube or any other medication that they provide. I think there is some continuity between what the Rajasthan High Court said that, well, you cannot just take your life, and on the other hand, they don't allow the protesters also not to take their life. There is an ethical issue about why doctors should be participating in providing force feeding is a different issue, but it is a part of the discourse in the human rights and ethics. Yeah. Any other question anybody may be having or comment that panelists can react to?
There's a comment in the chat box by Ravi ji.
Oh.
Should I read that out?
Yeah, please do it.
Ravi ji says that all presentations are excellent and together covered a wide array of concerns on this issue. Just want to make a point about the context of such decision making and bringing in legislation on this. The context of the healthcare system in the country is a critical factor around this. If we have a marketized healthcare system where health is a dhanda like in India, then any legislation on this is fraught with risks. But if we have a universal access to healthcare system, then a law would help, but this would mean framing the law on end of life as part of right to healthcare law so that there is a rights-based decision making.
Oh, yeah. What do you think? I think even if you look at the international scenario, the Europe and Canada, who are having more liberal laws related to this issue, they are universal access system countries as compared to, say, USA. Is USA also having similar kind of liberal law on this subject, or it is different? Because USA is a market-driven country.
Some states have a assisted dying legislation.
Some states have.
Yeah,
Yeah.
some states. But I think it's an important point what Amar is saying, wherever there's universal health care available, these acts work better. I think, I'm sure there's literature on this, but that is very evident from what we've been reading and hearing. Over.
I think it is important simply because when you have this legislation, they are working against the stream, particularly the moral ethos of the society, religious ethos of the society, which normally does not provide so strong a support to patients' right to make decisions of this kind. And brought in the market system, they may get more controversial, and that might create some negative aspects related to it as compared to when it is brought in the universal access system, where there will be conflict and debates, but there will not be very antagonistic position within the society to do away with the law. So I think that is more possible scenario that we can see, that in India, as you said, that law can only be minimal ethics, right? But the larger ethics is social and moral order of the society. If we are able to change it, at least in terms of healthcare access, then and better regulation for ethical conduct of doctors and the institutions, then both of them can supplement each other well to make this law successful. Yeah. Anybody else? Vibhuti, you want to say?
Even if there is a universal access, multiple marginalities and intersection vulnerabilities are there. Whose life is more important? Suppose you are in a very wealthy family. I know that I've seen in so many upper class families in Gujarat, where for men, if man has certain problem, we saw even in case of HIV/AIDS, no? If man had HIV/AIDS, then he was cared for by the family. While in case of women, they were abandoned. So I think similarly for a long-term terminal illnesses also, I think these biases were still there, even if you have universal access, no? What do you say, Dr. Kaustubh?
So gender and caste issues are...
Gender, caste, ethnicity, even class.
I remember I was called to an hospital long back. I think it was 20 years back. They in a private hospital where they observed that in the ICU, when a woman was in the ICU and required long-term care, the family actually abandoned the care and took away the woman and allowed her to die at home.
Correct.
But if it was a man, they went to the extent of selling all their assets to pressurize the hospital to continue with the even futile care for the person. So there is a moral and gender dimension here. Yes, there are.
Whose life is more valuable, no?
Yeah.
That kind of.
So just to kind of, complement this conversation, I think there's literature even from global literature which says that even the people who are seeking the assisted dying, it's mostly comes from women. So there is a gender dynamics there as
Nobody
well.
to look
And
after.
within those frameworks where there is universal health care, more of women, and I don't remember now what exactly were the context in which, but that was the gender differentials as who the more numbers of women seeking the medically assisted dying kind of thing.
And any long-term illnesses, women care for the family members, but when woman herself becomes...
Absolutely. It's such a gendered care that the entire globally we have gendered care system.
Correct.
Dr. Dhvani, you want to respond to this? And then Kaustubh, yeah.
I fully agree with that. As I said, that there's therefore, I know the kinds of the misuse that the courts talk about when they speak about withholding or withdrawal or assisted dying is they're worried about doctors colluding with relatives to take patients' property, etc. Now, I mean, that it may be a valid fear, but I think that one is a bit far-fetched. But what the issues that, Dr. Sunita and Professor Patel just raised are the real ones. What are the actually underlying reasons for decisions like this? And how do we ensure that the right considerations are taken into account while making decisions like this? And honestly, that can come only with a higher standard of ethics and a safety net of provision of other kinds of care, so that financial considerations are not a reason for taking decisions like this. And also just even private hospitals. I mean, whatever, we are in Delhi here, and I have come across only two tertiary care fancy corporate hospitals that have a palliative medicine department. So it's not even, it's also a lack of prioritization of the kinds of treatment or care that the medical profession itself values. And I think that comes only with better training and incorporation in the curriculum and more awareness.
Even we as a women's group have also seen that if woman has any terminal illness, even HIV/AIDS or any other transmitted contagious disease, she's abandoned by the family. She ends up in women's groups, or she ends up with the police committed shelter homes. No, yeah.
Dr. Kaustubh?
Yeah, no, my limited point, going back to your earlier point and what Ravi also raised, I think I also agree, right to healthcare should be the front end of all this, because unless and until we have right to healthcare, I think universal access, and even if we have to work on the structural issues of gender and caste, won't be possible. So that's my opinion. I fully agree with what discussion is happening. Just another information with Mental Health Care Act now, this is a funny situation. We have a right to mental health care, but we don't have a right to general health care. So I think Mental Health Care Act actually gives that ground to push the movement towards right to health care, because now government has signed, at least said right to mental health care is there. So I think there has to be a push around right to healthcare, because we at mental health, we are facing a huge access issues. The treatment gap in mental health is almost 80 to 90%. And then this issue about access is largely because, it's all about market, and only, concentrated, the access is only concentrated in urban elite societies for mental health. So so right to
And we are
healthcare.
also approached by the in-laws and the family members when the property matters is there to give mentally ill certificate for a person. That is and that happens in collusion with the psychiatrist. So they want a second opinion from the women's group. They approach.
Anyway, I think we are reaching to the end of the session. I think this point is well taken, and everybody agrees that we do require universal access to healthcare, but not just simple universal access, but with a targeted universal access, in the sense that there are people within the society who are underprivileged and less powerful. They need to be protected much more in the universal access than everybody. It's like a difference between equality and equity. So it's not just treating oranges and apples as one fruit, but they are different fruits. There are some people who need more protection even within the universal access system. If that is not provided, then the gender, caste, race dimensions, even in the universal access, also play out. So they are not very easy to handle. It's not just about market, but even in the non-market setting, non-financial social issues are also to be looked at. The other thing that I learned, and I'm very happy that there is some progress being made, even in this such a bad system that we have. And this progress is going to happen simply because there are people who do request, demand their right to end their life when they are in a really facing a very bad quality of life due to the terminal illness they are suffering from, or any other areas of the issues which are there. So we have guidelines. They are a little bit more bureaucratic, as Dr. Dhvani was explaining. But unless we start using even the bureaucratic guidelines, we will not be able to feel confident about how to simplify them. So I hope more and more people who know about it and know how to properly actually implement these guidelines, so that some of the people who need it, they don't have to go up to the Supreme Court to get their right on this subject. So yes, we need this experiment, need these efforts to continue and continuously balance them, so that the misuse is minimal. We can't have an absolutely no misuse. That kind of society may not exist ever, but we have to ensure that it is minimal and there is a good monitoring on this. So I learned a lot, and I hope the discussion on this subject will continue, because only then we will be able to do something. And I hope everybody who is making efforts in the advocacy to get a legislation, a comprehensive legislation, which can answer as many issues as possible and provides not just right to terminate one's life when really has no hope left in the life, as well as provide safeguards which are needed to ensure that it is done in an ethical and dignified way for the person involved. So I think that efforts needs to be continued, and all of us need to join hands in taking it forward. If there are no other questions or other comments, and any one of you want to have a last word, you are at liberty to do it. We are very, very flexible about it. And then Mansi can end the session. Any comment that you would like to make before you go? Okay, Mansi, please.
Thank you, sir. We are deeply grateful to all the panelists for this insightful discussion, and thank you to the participants for your thoughtful questions and active engagement. Thank you. With this, I would like to proceed to a formal vote of thanks. As we conclude this panel discussion on medical life support withdrawal and assisted deaths, social, ethical, and legal issues, I am Mansi Verma, on behalf of IMPRI Center for Human Dignity and Development, New Delhi, extend my heartfelt gratitude. Our deepest thanks to our chair and experts for today. Thank you to all for esteemed panelists for their insightful and thought-provoking addresses. Your expertise and perspectives have greatly enriched today's discussion and provided us with valuable takeaways on this critical topic. We deeply appreciate your time and contributions. We also thank all participants who joined us live, raised pertinent questions, and contributed to today's dialogue. For those watching later on our YouTube channel, listening to podcasts, or reading our publications, we deeply value your engagement and interest. We hope you continue to join in future IMPRI Web Policy Talk and Web Policy Learning programs. Wishing you all a wonderful evening. Thank you.
Thank you, and bye-bye.
Thank you.
Thank you.